So the slides I'm using for this are really shared between Geert and me. Either of us could have come up here and given the talk on my slides. I could have given it on his slide. Because what I'm talking about is the result of a really quite accurate review article that Geert, I, and Ian Bagley from Australia wrote on paroxysmal sympathetic hyperactivity. And I'm going to talk about just the main points in a very practical sort of way. So this is the history first described by Wilder Penfield and in a patient with a thalamic tumor who had episodes of abnormal sweating, hypertension, and eventually died. And he thought that this was epilepsy. He called it diencephalic epilepsy because it was coming from the diencephalon. It isn't epilepsy because when you look at the origin of the word epilepsy, it doesn't fit. And most importantly, there's no evidence of seizure activity of the EEG. So we're not entirely certain what is causing these abnormalities, but let's first see what it looks like. So this is a patient from Geert's unit, and what you have is episodes of rising blood pressure, heart rate, and central temperature. So you get some of the cardinal features of this, spasms of tachycardia, hypertension, raised temperature, and also sweating and muscle activity with tonic spasms. And there were a lot of names associated with this: dysautonomia, sympathetic storming. But finally, after a long process, which I won't go into, Ian Bagley, myself, and a group decided on a diagnosis being called paroxysmal sympathetic hyperactivity. That went to a consensus conference, and finally that's what resulted in it. It's a syndrome recognized in a subgroup of patients with severe acquired brain injury of simultaneous paroxysmal transient increases in sympathetic activity, heart rate, blood pressure, respiratory rate, temperature, sweating, and motor posturing activity. So how to diagnose it? What Ian and his colleagues did was to create this, the PSH, paroxysmal sympathetic hyperactivity assessment measure, which consists of two parts. There's the clinical feature scale, which tells you whether the features fit in, and you score between 1 and 3 on a set of 6 features. And then there's a likelihood tool, which tells you how likely this is going to be PSH given the context that it's in. You score both of those, put them together, and you get a score, and it tells you whether it's likely or not to be. And there's a lot of literature now showing that this is easy to use, that it's reproducible, and does result in diagnoses that can be supported. So that's how you diagnose it. It's a clinical diagnosis, not a radiological or blood test-based one. What's the basis? The basis is this, that normally there are inhibitory pathways coming down from the brainstem with cortical control, and they affect spinal motor and sensory loops. So non-nociceptive sensations are not triggering motor and sympathetic responses. However, when you have brain injury, and typically it's diffuse injury, but often involving the brainstem, these inhibitory pathways are actually affected. They don't hit these loops as well as they should. And locally, there develops a self-propagating loop of activity, so that non-nociceptive stimuli are interpreted at spinal level and perhaps even slightly higher as nociceptive. As an aside, when Geert and I drew this diagram the first time, we were very pleased with it and went away. And then we had a letter from someone in India saying, I hesitate to point this out to you because it's a very nice paper, but the pathways are wrong. The sensory outputs are going out and the motor outputs are coming in. So you have to correct the diagram. So there you go. So this is the excitatory inhibitory ratio model of the pathogenesis of paroxysmal sympathetic hyperactivity. Where's the injury? Don't know. I mean, there are lots of studies. The suggestion is that traumatic axonal injury in the context of traumatic brain injury or widespread brain injury in other diagnoses is responsible. It's difficult to be certain because it occurs in the most severe kinds of brain injury, and the most severe kinds of brain injury typically have distributed injury. So to actually find out that there is a PSH center in the brain makes it very difficult. It sounds as though it's a disconnection syndrome, and everything that we know seems to fit with it. So there's this paper which showed that it was primarily associated with axonal injury, and then affected the corpus callosum and the diencephalon and the upper pons in the dorsolateral midbrain. And then there was this paper from Holly Hinson, Robert Stevens, and Louis Puy-Basset, amongst others, which actually undertook a PCA analysis and found that the usual suspects were there. It's white matter injury in parts of the brain where you would expect to see traumatic axonal injury. So how to make the diagnosis other than the clinical features? Well, one thing you can find out is quite early on when you have a stereotype stimulus, and in our clinic, in our unit, what we do is use tracheal suction. Often these patients will have a tracheostomy and will not be sedated, but they're not waking up. If you use tracheal suction, everyone will have some increase in heart rate, but what will happen in these patients is they go through a phase of sustained autonomic arousal without actually having paroxysms of sympathetic hyperactivity, so that they become a little more responsive, and then finally they develop the sustained picture. So after an initial stimulus that's perceived as nociceptive, it doesn't get back to baseline, it just keeps firing, and you have a persistent tachycardia for much longer. What is the underlying cause for this? So there's been this study that was from Fernandez Ortega and colleagues, where they looked at ACTH, cortisol, and a variety of monoamine transmitters. And this is in patients who are not storming. There's some variability from time to time. But if you compare it with patients having episodes of PSH, you don't see you see some changes in ACTH and cortisol, but the big changes you see are in norepinephrine, epinephrine, and dopamine. So it looks as though it is truly a sympathetic driven process. So why are we worried about this? What is the impact on outcome? So there are lots of studies which are reviewed in the paper. You can have a look at it. But in brief, what it looks as though is that paroxysmal sympathetic hyperactivity has a significant impact on ICU outcomes. Because you're dealing with these paroxysms, they often stay in the ICU for longer. They often get a tracheostomy, though the jury's a bit out on that. And they very often may stay ventilated longer because you wind up sedating them. There is an independent association with long-term outcomes, but it's very difficult to know whether it's bad brain injury causing worse outcomes and PSH, or PSH causing the worst outcomes. So the causality is difficult to pin down. So how do we treat the condition? You start off with supportive management, you suppress sympathetic outflow, suppress allodynic response, and then you can use neuromodulation. The supportive measures are really important. Physiotherapy, splints, positioning, temperature control, and nutrition are important. These patients are very often hypercatabolic and will require more energy than you would normally assume an intensive care patient would require. So their calorific requirements needs to be looked at. Temperature control contributes to this. So if you can get on top of the temperature, that would be great. Surface cooling and paracetamol, acetaminophen for our American colleagues is reasonably effective, but one thing we have found very effective are low-dose infusions of diclofenac, which has been described by Giuseppe Cetterio from Monza, and patients who don't have renal dysfunction and are relatively euvolemic, then using those drugs often will get on top of the fever much better than the other measures will. It's very important to make sure they're euvolemic and they don't have a high urea, because these patients sweat buckets and sometimes will become water depleted quite severely. And then in terms of using the nutrition, the daily calorie requirements can be increased by 50 to 40%, and the VO2 during paroxysms by up to 300%. So you have to take this into account, and very often, most of our patients who have bad brain injury will lose weight in their hospital stay, but these patients really waste away because they're burning up their muscle if you don't give them calories. There's a whole host of drugs that have been tried with varying degrees of success, and I'll go through them one by one, but very simply, there are opioids, IV anesthetics, beta blockers, alpha-2 agonists, neuromodulators, benzodiazepines, and to some extent dantrolene. What about opioids? Well, they're effective for both prophylaxis and treatment. They're often used in the initial ICU phase. The side effects are a problem with chronic therapy, but sometimes they're unavoidable. They have to be used, and we have used them. IV opioids can be used for paroxysms. It's dictated by local practice. We try very hard not to, because it can confound neurological assessment in these patients, but we occasionally have to do it. So for prevention, you need long-acting opioids. We've used sustained release preparations, morphine sulfate granules, or a fentanyl patch. But my personal opinion, though we don't always succeed in doing it, is to try and come down to the opioids as much as possible because we worry about it. Beta blockers are a mainstay of treatment, and these reduce circulating catecholamines, and they also reduce metabolic rate because that is sympathetically driven. The counterpart of the patient who receives an adrenaline infusion as an inotrope and pushes up his lactate because of increased glycolysis. So a variety of drugs have been used. Metoprolol and labetalol are not that effective, but propranolol is the mainstay, and because it's mainstay because it's non-cardioselective, but it's also lipophilic, so it gets into the brain and affects beta sites in the brain as well. So propranolol is probably the first choice. Alpha-2 agonists have been used. We've had quite a lot of benefit from clonidine, either given intravenously or enterally. It has both central and peripheral effects. It has effects of the cardiovascular system and reduces circulating catecholamines. But there's obviously some difference in the mechanism because it's less effective for temperature control and doesn't really sort out the paroxysms of responsiveness, but the baseline effects are quite useful. There's a little bit of data on dexmedetomidine, and this rather strange paper suggested that prophylaxis with dexmedetomidine prevented the onset. I have to say I'm skeptical about it, but I put it up. I'm skeptical about most things with dexmedetomidine, so I have to counterbalance that with being as open as I can. Other drugs, gabapentin, anticonvulsant, a neuromodulator, it probably acts at specific presynaptic calcium channels. It does seem to be efficacious at spasticity and allodynic responses. It's probably more effective in the mild or the chronic case. In the really full-blown acute case, it's usually opioids and beta blockers that tend to be most effective. In some patients, there's very little literature on pregabalin. In some patients where we are not succeeding with gabapentin, we have tried pregabalin, and because the pharmacokinetics are much more linear in terms of dose resulting in pharmacodynamic effect, sometimes pregabalin has worked. This is a personal anecdote when gabapentin is not. Baclofen has been used. You can understand why it might be effective because it acts on inhibitory interneurons in the spinal cord. Typically, enteral baclofen hasn't been that helpful. Intrathecal baclofen at 100 to 200 micrograms per day has been helpful. The oral baclofen, the jury's out on it, it's plus minus. It has variable impact on sympathetic symptoms, and it's much more consistent, that effect with intrathecal baclofen. And then there's a case report of hyperbaric oxygen. It comes in the same class as dexmedetomidine. I want to be impartial, so I'll show you the paper. Maybe it's going to be the most fantastic thing, but I haven't got any experience with it. So here's your summary and take-home messages. It's a clinical syndrome, very likely heterogeneous, multiple etiologies, increased sympathetic activity and hyperresponsiveness after brain injury, likely a central disconnection with traumatic axonal injury from TBI being the most common, but also being seen in things like hypoxic injury and stroke as well. Opioid sedative withdrawal is an important confound. So all our patients in the intensive care unit were likely to have been on high doses of opioids, and when we withdraw the opioids, they may just be kicking their habit cold turkey. And none of the papers that I've seen has actually addressed that possibility. And maybe just a slower tapering of opioids might help. In that context, I think that remifentanil is particularly a problem because you see much more withdrawal with it. First of all, because of the pharmacokinetics, it clears very quickly. So if patients have been on it for a long period of time, you drop levels very quickly. But the second thing is it seems to be pharmacodynamically slightly different from the other opioids. Bev Osner's work from Toronto has shown that if you look at cell cultures, remifentanil can upregulate NMDA receptors much more quickly than morphine or fentanyl can. So there seems to be a pharmacodynamic effect. There's a significant impact on outcome from PSH, at least in the acute stage. There are recent consensus definitions and clinical monitoring. This should allow better monitoring and objective assessment of treatment effects. Supportive care is really important. Posture, nutrition, and temperature control. Current therapies are inconsistently applied and variably effective. Opioids, beta blockers, and probably gabapentin or pregabalin are drugs of first choice. Other things are second choice. And these are in small numbers in any center. So if you want to make an impact on this condition, we need collaborative studies between centers who are seeing lots of these patients. Thank you very much.